Good evening, everybody. Thank you for taking the time tonight to join us. We're very excited to present to you. So just starting off, my name is Sherry.
And I'm 𝗧cie𝗽𝗶𝗰𝘀.
And we're two PGY2 residents from the Sunnybrook site of U of T. We're working on an active demo project to identify some areas of practice management need and to produce some resources for new family doctors and new grads to help them optimize their practice.
Right. So based on our initial survey that we just had done before, we had seen what did people want to learn about. And so you can see we had pulled different sites. So Sunnybrook, Queen's University as well, McMaster, and also we posted on the Facebook first 5 years as a family doctor in Ontario group. And so we had a really good response rate for in the Facebook group especially. So people really wanted to learn about practice efficiency tips and contract do's and don'ts, among other things. Here you can see McMaster as well. Practice efficiency tips was the top one, and certainly on the Facebook group. So based on our initial survey of the new grads and residents, we were able to see what they wanted to learn about. And so we will do a series of different topics, and we thought that the first one could be the practice efficiency one. So basically to help the people or new grads, new residents starting the practice soon, so to help those people out.
Yeah, so today we have a presentation followed by discussion time to give you some practical tips on reducing admin burden and charting efficiency. If you have any questions at any point, just post them in the Q&A and we will have time in the last 20 minutes of the talk to address them. Or if you have any other suggestions or just want to share things, you can also post them as well. Starting off, so we have our guest speaker, Dr. Sarah Smith from the charting coach, followed by a panel discussion with Dr. Smith and Dr. Stephanie Zhou, who also teaches billing and practice management lectures at U of T Family Medicine. And she creates also videos about financial and career education on YouTube as well at Breaking Bad Debt, which you might have heard before. Also, just to briefly introduce Dr. Smith, she is a rural family physician from Alberta, so she's joining us today to teach us a little bit about what she knows. So Dr. Smith, I'll let you share your screen now and begin your part of the talk.
Overview, and then you can fill in the gaps as you progress in your clinical career. I'm just so excited to have you all here as newbies, yay, as colleagues. So I just honor you as part of our family medicine. I am a family doctor. I'm practicing in Edson, Alberta. I do rural emergency department as well as have a panel of patients and inpatient care. And there's a podcast I have called Sustainable Clinical Medicine. If you're interested in learning some of the stories from others who have redesigned their clinical day to make life more sustainable within their clinical day. So you may have already had this experience, even as a resident. The last patient leaves and there's still a whole lot of things to do before you can go home. Or maybe you have to run home because you've got to get to something, but there's still unfinished work from the day. How do you feel when this happens to you? So if you can grab the webinar chat and just let us know kind of what sort of things are you experiencing when the clinical day spills out and over the time of the day. Common ones would be overwhelmed, frustrated, miserable, dread. Okay, it's not the fun part. And the thing about this is if you don't have this experience of thinking about the clinical day, the business of the clinical day from a step back and look at the clinical day, then you'll just be carried along within the clinical day when no one else respects your time. Our time is our responsibility. So I was 15 years in and still having this experience of family medicine. So it doesn't just get better, but it's a skill set you can learn. And hopefully by getting you this early in your career, we're going to save you hundreds of hours of evening and weekend charting and everything about family medicine. But these were sentences in my head. Where do I even start? I'm never done. Does it ever end? Will I ever figure this out? Okay, So this is just a lesson from the other side to say it doesn't just get better, but it's a skill set that you can implement. So navigating that clinical day is a skill set you can learn and apply to every workplace. So let's take a look at the clinical day. We'll think about it in two different sections. The protected patient time, where we're seeing patients and closing charts. And I say protected patient time because you will be interrupted. You will have other things coming up within that time. So unless you're thinking about it as protected patient time, it can often create more problems with regards to running on time and getting too far behind in the day. And now I'm feeling rushed and awful about the clinical day. So thinking about those segments of the day where you're seeing patients as protected patient time. And then everything else. So I actually went for years thinking, well, not thinking about everything else. It was just shit that happened to me within the clinical day. The patient messages, the in-basket, the questions, the interruptions. There was no thought about it. It was just things that happened and carried me along in my day that ended up as this mountain at the end of the day of unfinished tasks. So what's in there? As you move into different workplaces, you'll have different expectations of your time. You'll have different types of portals, different types of patient messages coming in, different in-baskets. You may have siloed work lists. They're our favorite, where you have to go into a hospital system to check out that in-basket, back into your EMR to check another in-basket. Each of these has a time requirement on you. There'll be consultation letters coming back. There'll be meetings to attend. There'll be people tapping you on the shoulder saying, hey, you'd be really good on this committee. Okay. So all of this has a time requirement. So we start to just step back and think, what is in my day? What do I need to get done within my day? What am I saying yes to? All right. Here are the 4 overarching principles that I teach physicians. And look, I look after physicians who are residents all the way up to their last 2 years of practice, right before they retire. They're like, where were you 20 years ago? So these are skills that are valuable to you, and you do not have to master them by tomorrow afternoon. Please hear that. This is a journey, but these are your toolbox. So these are our foundational steps. Step 1 is completing your charting after every patient. Who thinks that's possible for them right now? Do we have any outstanding stars here who are already, yep, we got that one, tick. Or if not, why not? What gets in the way of you getting your charts done? If you have answers, pop them in the chat. Step 2, leading your clinical encounters. We'll dive into what that means in a moment. Your exact plan for everything else, right? The inboxes, the patient portal messages, the emails, the study for the exams, whatever that everything else is. And then managing your interruptions. All right, so completing your charting after every patient. Now, we don't have long tonight together, so I'm just going to go through this super fast from a broad spectrum, but you're just going to pop it in your head as an idea. And then as you're going into the next few days, you get to practice this with every patient. You get to think about it as an idea. And how could I? So completing your charting after every patient, even when, oh, I'm 20 minutes behind. Oh, there's a crying baby in the next room. Oh, whatever that looks like, right? How would this be possible? We start looking at what is in your notes and why. You are always the boss of your charts and documentation. You know what belongs in there for medico-legal reasons, for your college reasons. You know what you need to record in terms of what happened within the consultation, your pertinent positives and negatives, the assessment and plan. But what else? Are we still writing paragraphs, and why? How else could we do this? What does your brain tell you is more important than the note? And you'll know the answer to this when you go to sit down and get that chart done tomorrow after this patient. What happens You jump out of that chair and dash into the next room because there's a patient waiting. Or you open the inbox to check out how many things are sitting in there or what messages have come in. What we do because that is what we have taught ourselves to do, okay? So we are trainable, and we've taught ourselves a familiar path of action that we will keep doing, whether it's helping us or not. Good and bad habits. This is part of that human experience, right? How and where could you get that note done if you wanted to? And this is going to change workplace to workplace, right? Sometimes you find yourself in a nice, quiet little office where you can shut the door. Brilliant. Other times you find yourself in this big, messy, loud pod where everybody talks to you. How easy is it to do that high-level work of the decision-making? How much of this can we get done in the room during the visit? And what stops you? What stops you? So as you start to think about doing this, you'll start to notice what gets in the way. For every obstacle, think of it like an obstacle course. As you start to solve for each of the things that gets in the way of you getting that note done after this patient, you will start to find your way in each workplace. So just keeping it in mind, you don't have to be a master of this. Just put this idea in your head that it's possible to see patients and close charts. Now what? How would I start to do that? Not, I don't know, but just letting your brain simmer on, that's an interesting idea. I wonder how that could be possible for me. Leading your clinical encounters. So we know that the clinical encounter, this is the time in the room with the patient, is an expensive piece of real estate in your day, right? This is your highest level work. And here's the good news. You're the boss. You may not feel like the boss yet, but you are the boss of what's going to happen in this room today with this person. We are going to have what they're coming in saying they're there for. We're going to have your agenda of what things you need to talk to them about. The negotiation of what's going to happen and what's not going to happen within this consultation today. Also, if you value running on time, we need to look at all the minutes and seconds. They now all matter. So if you walked in the room and you've walked out again to get your stethoscope, that's going to cost you at least a few seconds, if not an interruption as well. If you say yes to problem number 5 in the room, guess what? You now have to document 5 problems in the room. So when the patient says, oh, and by the way, can you refer me to the orthopedic surgeon for a knee replacement? And you're like, sure. Didn't take you very long, but now you've tasked yourself with either a referral right now or a referral later. So doing that referral letter is part of today's value for the patient, potentially. Or you might say, you know what? I'd love to put you on the list for that knee replacement. However, I'm going to need a new x-ray. Or let's do this other thing that we've decided is important today. And let's get you back so we can get you on that list. So you start to learn language that helps you with those patient encounters. You're not going to master it right away, but at least be observant to where those minutes and seconds are going. When you open up a blank lab form and you start ticking boxes, that is costing you seconds. What are some typical lab requisitions that you order? And set yourself up a template. It's going to save you some time. What are common things you do over and over? And how can you make that faster, easier? All of the minutes and seconds count, and all of your decisions consider the now and later in mind. My favorite one was at the end of the encounter, a patient would pull out a form and give it to me and say, here you go, you can do that later. Ha, when do we have later? Got so much on our plate already. Exact plan for inboxes, work list, and forms. So checking your work list between patients is going to be an expensive exercise in, oh, well, I don't have time for that right now. And now we're doing work twice. Or we look at it and we close it again because I don't know how to deal with that. Close it. It's costing us time. Now we're looking at it 3, 4, 5, 7 times. It's sitting in that in basket for weeks. As you figure out, how do I manage a low sodium? Remember it. Find that resource. Make it faster next time. Each of the workplaces you move into, ask them, how do I get this out of the inbox here? Because they may have set up a way that the team can help you navigate that. So just ask, how do we do forms here? Who's going to help me attach the X-ray and the MRI to this form? Who is that person here? Make sure you find out and find out early, because each of those tasks, you may be doing a lot of non-physician work. And interruptions. Don't we love those? Hey, Harry's late. Will you still see him? Now what happens? Your brain thinks, well, I'm 20 minutes behind. Harry's pretty complicated. I've got kid pickup at 4. No, you can reschedule him. If we'd taken that question, notice your interruptions. If that's one of the interruptions, start to be curious. Who did I need to tell this morning that I had kid pickup at 4 this afternoon? And give them blessing to rebook anyone who is more than X number of minutes late. Or find out what the policy is. If the policy at your workplace is, we see anyone whether they're late or not, then start to be curious. How will I see them in the room? Will I give them their full 20 minutes or 15 minutes? Or will I say, hey, let's get this in quickly today because we have some time change here, or we're putting you in anyway, even though you were unable to get here on time. So let's see what we need to do today, and just keeping it fast. Again, that's that language we have with patients. All right, thinking about your clinical day, you get to see number 10 for the day. All of the charting is done behind you. So every encounter that you've seen today, every aspect of that encounter is done, billed and closed. The chart's done, the referral letters are done, the orders are done, the requisitions are done, the notes are done and closed. What's different about walking into patient number 10, right? Isn't our brain much happier? Doesn't have 9 other patients rattling around in there to keep in mind. Our working memory is more available to us. And what gets to be different about our evenings when our charting is done? If we get to see that last patient and immediately we close that chart and we go home, that's fun. Now what do we get to do? And this is available to us, even in family medicine. So thinking about what's discouraging about my clinical day. As you work through different workplaces, you're starting to be curious. What do I dread about this? What am I discouraged about? What is taking up all this time? Get curious. What are some low-hanging fruit? What are some small or large changes you could start to put in place to get a more sustainable shift? What's the upside? Because we know doing things in a new way takes time and energy, it's unfamiliar, it's uncomfortable. What would make it worthwhile? And seek help. Do this with friends, colleagues, workplaces, communities. Get help. In Canada, here are some resources that are available to you. I run the Smarter Charting program, which is for residents and clinicians, and the Charting Champions program, which is more for the physicians who want to be in the program for longer. Either one is fine. There's 10-minute CBT for doctors. That's a great program. I've done it a couple of times. It's a way to help patients be advocates for their own health in a really short period of time, right? It's that language of how do we get the patient motivated for change. And things like AI scribing. So we know 𝗬𝗀 Health was developed by one of the Canadian family doctors as part of his master's program. That's the reason I mentioned that one. I don't have affiliation with any of the AI programs. Just know that change is hard, but not impossible. Take small steps and let it be messy. All right, we are done the presentation part. As I said, that's super fast. So hopefully we have some questions now so we can make it a little bit more relevant for you in the context that you are right now.
We do have some questions for the panelists from before, so the first one is basically for both of you, Dr. Smith and Dr. Zhou. Can you please talk about what got you interested in this area of charting efficiency and optimizing your practice?
Sure. Sarah, do you want to maybe take that one and then I can respond after you?
Yeah, so I was standing in my living room with my eldest kiddo in grade 10, and he was talking about university, and I thought, I'm going to miss out on his last 2 years at home because I'm still charting in the evenings and on the weekends. It was costing me so much of my life, and I was done with later. So that was my really big reason why I wanted to make this change for myself. It was all selfish to start with. And once I figured it out and created bucket loads of time in my life, I wanted to share that with all of you too. So that's why I came into this part of my practice.
Yeah, and for myself, how I became interested in practice management and efficient practice is I graduated and I started family practice in November of 2020. And so that was right in the middle of the pandemic. I was a new grad working very hard. I was actually working 7 days a week because a lot of the older doctors needed the younger doctors to take on more of the roles, given that I didn't have any dependents at the time, unlike some of the older doctors who had kids or elderly folks in their family. And 1 year into my practice, I found out that the person I had taken over the practice for, they actually took their life inside their office. And that's where I came in, and I ended up with their patient roster. And so I, like any new grad, I was pretty shocked that this was my first year experience in family medicine. And I later ended up Googling this person, and I read their rate my MDs and all their reviews. And it was all extremely positive. It was all like that they were the best doctor I ever had. Anytime, like the wait time was 2 hours, but when I came into the room, they gave me all the time in the world. They always stayed late, and sometimes I get to call them at 9 p.m. if I had an emergency. They were available 7 days a week to take my call. And then I realized, like, is it really that worth it to try to be the best doctor? Like, I later found out from colleagues of this person that, their marriage wasn't doing too well and their relationship with their kids weren't great either. And maybe it's those personal factors that led to their outcome. And so I made it I would try to be very intentional about not ending up like that myself, because at the time I was working 7 days a week. I was finishing clinic at like 9 p.m. myself. And so everything that doctor did, I try to do the opposite. So, the 2-hour wait time in the waiting rooms, I don't have any wait time. Everyone gets seen on time or early. And we can always talk about ways to kind of navigate when patients come in with a laundry list of issues. How you say it is more important than what you say. And in terms of, working 7 days a week, I don't do family medicine 7 days a week. I do family medicine 2 days a week, and I balance my other days with other stuff of interest to me, like teaching or administration. In terms of like, I can call my family doctor any time of the day. I try to establish really clear boundaries with my patients right at the meet and greet, so that they know that the other time in the evenings, the weekends, it's not for charting or for administrative work. They know from the get-go that that is time for me and my family and for my personal health, for instance. So I try to be very intentional in communicating my boundaries to my patients as well as my front desk staff, so they know that if someone comes in late for more than 30 minutes, it gets rebooked instead of everyone gets fit in until you're working until 9 p.m. So that's basically how I started getting into billing efficiency and practice efficiency.
Yeah. Thank you, Dr. Smith and Dr. Zhou. Very helpful. So we have another question here. So again, one of the biggest areas causing burnout is the offloading of work from other specialists or even other professionals, for example, naturopaths and chiropractors. And so that's adds to the burden of family medicine. So what do you do to reduce the burden of work coming from different specialists?
Sarah, do you want to take that one first?
Yeah, this can be part of looking at that appointment book advocacy and autonomy. So if your next available appointment is in 4 weeks, like literally there is nowhere else to put patients for the next 4 weeks, then we've done an error in your bookings, because you have patients coming out of hospital. You have things in your work list that now, if I don't have room to put them in to talk about this, now I'm going to have to call the patient. That's going to take me 10 minutes instead of like I need to see them within the next 7 days. So starting to be curious about what are the requests coming in and how do you want to handle them? You're the boss. So a naturopath request, please, my naturopath wants this and this. And I'll send a note to the staff saying appointment. And I'll talk to them and I'll ask them, what are you worried about? What are the symptoms going on? And if I think it's valued, sure, I'll order it. Or I'll say, no, they'll have to do this or that, and be happy to disappoint others. Just kind of like what Zhou was just saying. If you say, no, I'm not doing that, make it clear in your communication. Dear cardiologist, thank you for the request to do blah, blah, blah. I'm going to leave that in your hands. I'm not ordering it. Thank you for your time and for seeing my patient, right? So it's clear, yes, I'll do this. No, I won't do that. So the hepatologist would give us this huge list of things to order that are then my responsibility to understand how to interpret it based on the college rules of who ordered it is the most responsible physician. Now, when they copy them to me, I'll often just tick them off. Tick, 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 tick. If I see a critical potassium, I'm going to call my patient. I am choosing my rules to call my patient and say, hey, did you get a call from so-and-so already about this potassium? Yes or no? If it's a no, okay, this is what we're going to do. So you're the boss. You get to decide. Don't just be walked over. Don't be a mat. Decide, what are you saying yes to and why? And what is stopping you? So if you're like, I can't get them in to talk about this because I'm full up for the next 6 months, then we need to do one of those access readjustments. And that is a skill set that is doable. You can learn the skills of creating space in your calendar so you're not triple booking people all through your lunch when you've got a big inbox to manage. Don't do that to yourself. Be noticing, oh, I noticed that I can't get patients in. Access adjustment. Go manage that access. All right, sorry, Dr. Zhao's turn.
No, I think that's a great answer, and I completely agree. I think maybe in the interest of time, we can move on to the next question, because I know that a ton of questions in the webinar chat is popping up about AI Scribes.
Yeah. So
Right,
AI
so
Scribes, you need to have your privacy impact assessment done. So all of us need to submit to say, here's the people I want to work with, and here's their product description of where their servers are, what's kept on their server, that sort of thing. So do your due diligence with any AI company that you want to work with. So that's the reason I gave you the one that I gave you, was it was overseen by a physician and it was developed in Canada. That's my only reason. I haven't gone in to check all the other pieces of it. So do make sure you're doing that. And it's a tool for your toolbox. Will it fix your running on time or your charting? No, you still have to review the note that comes out of it, edit the note that comes out of it. You still have to do your referral letters, your orders, your scripts, all the other pieces. So it's a tool for your toolbox. It might save you a lot of time, but don't go adding 15 more things in the room just because you've got a scribe doing the work for you on the background.
Now, there are some questions in the webinar chat that specifically asked about AI Scribes that you recommend. You said
that's what I mean.
Kind of just work with one, right?
Yeah, I just gave you the one that was developed in Canada. I get to speak to a lot of them and they all do different things. So just check them out, have interviews with them, do their free trial, do it on a dummy patient, see what you think, but look at the back end of things as well. Like, are they going to keep the full verbatim? Does it come to you? Does it get deleted? Like all of that. Is it trainable? Because some of them have the servers that are trainable and some do not. So as you edit in the social information that you want in your note, it might learn to do that each time or it might not, depending on the processes that it has.
Gotcha. And I was also going to say that a lot of AI Scribes do have free trials. So I've personally used the Auto Scribe, I've used Tally AI, and I've also tried Empathia AI and Liddy. So I've tried 4 different ones, just trying the different free trial periods. Personally, myself, I didn't end up going with an AI scribe because I find the format of a lot of AI scribes is it will listen in on the patient conversation, but then you can't actually see the documentation until the end when they generate the SOAP note. And sometimes when patients have a very complex history or there's a lot going on, it's hard for me to remember what they said earlier. But if I'm having the note actually be generated in real time, like if I'm typing in real time, then it makes me easier. I could just look back at my previous sentence and remember what the patient told me. So the way that I tend to save a lot of time is actually through templates. And I know, and maybe at the end of the slides, I can share with you a folder that I have with all of my templates in there on a Google Sheet. And you can even copy and paste that for yourself as well.
Yeah, the thing about templates is make sure it's a usable template for you. So don't go getting a template that you have to now remove 3 pieces from every time. Like really make it your own. Or think about your workflow within the consultation and how you like to put things in. I like one big text box where everything goes in it. And then there's places in the chart where things will go, like the problem list and like the medications. But I'm kind of like Dr. Zhou, I'll do my own note. I don't use an AI scribe because I like to just dump the history, or I'll say to the patient, okay, pause there for a minute. What I heard you say was, and I will write the note. Headaches for the last 3 weeks, starting in the mornings. Is that correct? Never had any, you know, hasn't had this before. Like it'll be done in real time.
I've given some feedback to some AI scribe companies, specifically around translation in real time. Like if they can figure out a way to like be able to translate in real time what the patient is saying, that would be really valuable.
Yeah, there's a couple of AIs that I've told that and they're actually doing it. And if I can find the names of them, I'll bring them up. But they're, because we've got some physicians who have Spanish speaking and they're using a translator. I'm like, look, if you could have this transcription being put into English and Spanish in real time and they've got a screen and I've got a screen, that's going to increase your value here. They're like, oh, okay, we'll do that. And away they went.
There was a group of questions in the webinar that in the Q&A that was asking about privacy issues, consent forms around AI.
Yeah.
If you happen to know the answer to this, a lot of the questions were around, you know, it takes a lot of time explaining the consent to the patient and that slows you down.
Yeah.
So how do you kind of navigate that and the whole privacy issue in general?
Yeah, use your patient and use your EMR. So some EMRs you can send forms ahead of time. So you can send them a form like your PQ9s for your depression. You could send them the form for a new patient and tell me your past history, tell me your medications. You can send that ahead of time. So use your patient where possible. And then in the room with the patient, if it's someone you know, you can let them know and find the shortest amount of words that makes it easy for them to understand. There's going to be an AI listening to create a note because that's going to save me time so I can see you faster. Oh, okay, right? And then here's the wordy terms and conditions if you want to take that home and read it. Okay, so just finding the words that work for you and your patient. I saw this question up here. I'm running 30 minutes behind. Do I still prioritize finishing the patient chart? Listen, when you're first learning this skill, you can put that one down and move to the next one. You don't have to have every patient tomorrow. But yes, so you can make the next patient wait and you are going to do this chart in record time because there's a patient waiting versus I'll do that one later. And then I'm too tired tonight. And then I don't want to do it at Saturday. It's beautiful out. And then 3 weeks later, you're like, what the heck did I see them for? I hate this. This is so awful. It takes you at least a half an hour of digging around that chart. Make this commitment to yourself. I will never leave an empty chart. I will always leave myself breadcrumbs. Okay, so if you decide I am too busy, I'm an hour and a half behind, I cannot do this today, commit to breadcrumbs. Okay, no empty charts. Let that be your very first step, if nothing else.
And that is a really good piece of advice because I find that you remember the patient case much better when you're doing it right after the patient instead of at the end of the day. And if you were trying to remember the 30th patient or however many patients you've had at the end of the day, it's much harder to recall the information, and medically, legally, you might miss out on certain information that you talk to the patient about in your documentation. And so I also do the same as you, Sarah, like just finishing the chart with every patient, make the other patients wait in the meantime.
Mm-hmm. Crowning, coding, bleeding, seizing, then I might stop my charting and go.
Yeah.
It's really going to take a lot.
So we did take a little bit of a segue there from some of the pre-submitted questions to talk about AI. But 𝗧cie𝗶𝗰𝘀, I'll let you continue with some of the other pre-submitted questions.
Right. So the next question was prescription refills do take up a big chunk of time in our daily tasks.
Yes.
So how do you deal with refills quickly? And do you implement a block fee?
Okay, great questions. I'm going to give you my answer. So don't do what I did, which is I said yes to doing script refills because I wanted to, and I didn't charge for them, and that's silly. So now when we have a look at the workflow and how long it actually literally takes you and your staff to do script refills, there's things that can help make it faster and charge appropriately. Just learn early your value, okay? Charge for script renewals or block fees, whichever is more appropriate for you, because there's a lot of money you're leaving on the table, and that's money to pay your staff. Okay, so you charge the patient for that script refill, that's 1 hour of your staff being paid. You've got to think about the business of medicine in addition to, it's my patient, my beautiful patient, I don't want to have to charge them money, stop it. Okay, but think about how you refill a script. There could be a team member that could help you. Keep that in mind. It's not always physician work, but the thyroid needs to be renewed, right? Just a synthroid being renewed. Why are they on synthroid? Or a good one is a statin, okay? The simvastatin is being renewed. Uh-oh, why are they on that? When do I ask you lipids? There is a free text box in most EMRs about prescriptions. Save yourself 8 minutes of digging through the chart. When you do that script for the simvastatin for the first time, right in the free text box, primary prevention for diabetes. Boom. Now you know why you're prescribing it, and it's a quick renew and send when it's time to renew it. Not, why are they on that? Oh, man. Or when the patient says, why am I on that? You're like, oh, no. How am I going to find that answer? Be nice to your future self.
Yeah, and I do know a lot of clinics that do charge block fees. So patients can have block fee, like pay the block fee, or they can do it like a la carte as well.
Mm-hmm.
And that, from what I've heard from my colleagues, it's significantly cut down on their inbox when it comes to pharmacy refills. How we do it in our clinic is I usually have my patients book a phone appointment for refills. Usually these are actually really quick phone appointments, and sometimes they can even be double booked in the day where I can just call them. They take like less than a minute. Sometimes some of them are 30 seconds, and that allows you to bill for it while also chatting with the patient to make sure that they're taking the prescription correctly. If they try to reintroduce another issue in the phone call, I usually try to set my boundary there, and I tell them, oh, you know, the purpose of today's visit is just for a prescription refill. Let's book another phone call to talk about your other issue.
Yeah, exactly. And renew for long enough. Don't hold the patient hostage like you do a 3-month script, because then they have to come back for a renewal, because now you're like, and then I'll do 1 month, then I'll do a week. No, now you're adding burden to your day. If this is a stable patient, you just do the longest renewable, and you'll just change it up if things change in the meantime. So that's another way, is those, how long you're giving scripts for, because that's going to make a big difference. Obviously, some of your protected medications don't get 12 months, but some of them are fine to do for 12 months.
Maybe we'll take a question from the Q&A and we'll try to alternate. I see that one of the upvoted question was about concrete strategies for residents to chart more efficiently when we don't always have control over our timing or our environment.
Yes.
What would you say to that?
Okay, absolutely. All of you are within an environment where you see X number of patients per day on X number of length of appointment, whether you've had the choice or not about the length of appointment. It's your job the boss of the clinical encounter, to know I have 15 minutes. It's going to take me 5 minutes to chart and orientate myself to who this patient is. That means I have 10 minutes with the patient. Now every minute matters. So how we start and end conversations is important. Not, how are you today? That's a 3-minute cost minimum. Versus, what are we doing for you today? Why are you here today? What brought you in today? Whatever that word is that gets us started. 10 minutes. If you don't have time awareness, some of you have ADHD, some of you are just so overwhelmed with what's happening in the day. Woof, 40 minutes later, you're like, wow, what happened? Find a strategy for time awareness. There are so many options out there. Amazon sells them to you. They'll have them to you tomorrow, right? Many options for how to stay on time. And when we get to that 8-10 minute reminder, you're like, okay, time to wrap things up today. Oh, but I still need. Okay, there's always going to be one of them. Great, that's a great question. I would love to dive into that with you. We're going to get you back for that. Not, is there anything else? That's at least another 3 minutes. Nice seeing you today. Is going to wrap it up faster. So just keeping that in mind. So whatever you're given, time-wise, start being curious about how am I going to run this appointment to stay in that time.
Yeah, and I think I posted this in the chat, but when I was a resident, a lot of my colleagues were leaving at 7 p.m., but I basically tried to leave at around 4:30, and everyone thought I had a chill schedule, but actually it was because I started building templates. I posted in the chat the YouTube video where you can find the Google Drive where my templates are. I think I based my templates based on the 99 topics, because those were the topics we needed to know in family medicine. Now it's 105 topics. And they're usually for things that are like very common. So like MSEs or UTIs, PAP tests, everything where the documentation is constantly the same, very little variation. Anytime I wrote out like a plan for a patient in the SOAP note, I would copy that onto a Google Sheet. And I've been encouraging chief residents to organize these template shareable Google Sheets with their colleagues, because that way, regardless of which EMR you use, you can bring that Google Sheet with you anywhere and copy and paste those templates. One other thing, because I know there were several questions about medical legal stuff when it comes to documentation. In all of my templates, I always have red flags to counsel the patient on. So for example, if it was something related to appendicitis or abdo pain, I'll usually have some red flag symptoms embedded in the plan of the template itself. So even if I forget to ask, when I copy the template on, it jogs my memory to tell the patient about those red flags and to go to the ER if they have those symptoms. So at least I have that medical legal bit covered.
Love it. So good.
Thank you. We have another question. So new grads are getting more anxious about patient complaints to the college. And mostly they're worried that if they don't let the patient fully explain all their concerns in the visit or get to all the items that they came in with, they'll miss something or the patient won't be satisfied with their care. So what do you do about patients who have multiple issues that are complex and have demands?
Love this question. Okay, so you can spend half a day with the patient and their brain might decide they didn't do a good job. I'm not satisfied. What? How is that possible? Right? You've given your all. So you have this expectation that if I do this, this, and this, the patient will be satisfied. However, what you do is just a fact in their life, okay? Their brain is going to make a sentence about it that creates the feeling of satisfied or unsatisfied, okay? It's not you who gets to create satisfied in their head. So even if you listen, you attend every problem, you put them immediately on that referral list, they might walk out and decide that you get a 1 out of 5 because the secretary didn't smile at them correctly today. It's nothing to do with you. Other people's opinions are none of your business. Now that's hard to say when you're like, but they're going to complain to the college. Listen, the college is going to take those types of complaints, look at them and be like, okay, it's not a malpractice piece. You decide that you are turning up professional. You're going to give your best always. And you hold yourself as, I'm an amazing doctor that is available to you. That thought is your brain. Do not rely on the happiness or the feedback of your patients to decide that you're a good doctor. You are an amazing doctor. And you are a problem solver, troubleshooter. So when things go wrong, the patient with abdo pain ended up with appendicitis in the hospital tomorrow morning, and you decide to put shame and guilt on yourself. Okay, pause. When I saw them, it wasn't an acute appendicitis. It wasn't even in their right lower quadrant. The story I had at the time, with the information I had, I did my best. Now, what could I learn? Comes from a different place. What could I learn from this? Well, I could learn that the patient listened to me and went to the hospital because it got worse. Brilliant. I'm a good doctor. Okay. You cannot control whether patients have appendicitis or not. That's not your job either. We want to hold ourselves accountable to patient outcomes. Watch that too. Very important for young players and all players. All of us do it to ourselves. Take a minute. It's really confronting when something happens to your patient, good or bad, right? Really confronting. You can have high emotions about that. Seek help, talk to others, because shame grows in the dark. If you hold it inside, it's going to get bigger and uglier, and you're going to have a bad time. Please tell someone. Have those people in your life that you can text and say, do you have 8 minutes? Someone you can just dump on. This happened. I feel like shit. I did something wrong. They're like, yeah, I did that too. I've done that dozens of times in my career. What? Yeah. Huh. And you still respect me. Funny. Wow. Okay. Right. So just keep that in mind. You're not going to have a perfect career because you spent 45 minutes with every patient seeing all of their problems. That is not protective of you.
Yeah, that was, I saw like 5 people ask that same question or some variation of that question in the Q&A. And like I said before, you know, how you say it is more important than what you say, because what you want to say is like, look, I only have 15 minutes booked, 1 issue per visit. Like when you say it like that, the patient's going to get upset and maybe they'll put a patient complaint against you. So what I usually say is, you know, I understand that all of your concerns are important, but I'm very careful and I don't want to make mistakes. And often when you're juggling multiple balls in the air, it's more likely for you to make a mistake and something gets dropped, like a referral gets forgotten or a lab is forgotten. And so how about I just list all of your issues down first, or if you have a list, let me just take a look at this list and let's choose 1 or 2 of those things together to focus on this appointment so that we can address it completely instead of juggling a lot of balls in the air. So that's exactly how I say it to the patient, and they're very understanding. They know that it is easy to book another appointment, and it saves me a lot of time because I'm able to finish the visit in the amount of time I have. And because my schedule is very efficient, patients can actually book with me same week if they wanted to. So I don't have a 2-week or a 4-week wait list because I try to maintain those time boundaries.
Yeah, beautiful.
Thank you. Another question. So for a new grad doing intake appointments with the new patients, sometimes they bring a USB or a really big chart with over 100 pages. So are we expected to review their note, their whole chart, or do you have how do you go about that?
Oh, I love this question. Good question, people. So think about, what am I expecting to have achieved by the end of the first visit with a patient? Okay, so a new patient comes in and you're maybe deciding if they're going to be on your panel or not. But typically they, 1, come in with a problem. They don't normally come in and say, hi, I'm just here to meet you. That would be delightful. Rarely happens. Normally they're like, hi, I'm here with, knee pain, back pain, chest pain, whatever, and I'm new to you. So think about it from an urgent care perspective, right? You don't have the whole file yet. So what do I need to know about you, sir, in the context of this back pain? You know, is this something new? Is it, oh, so you're going to do that initial visit. But then think about this. You could have a rule that says all new patients have 3 visits minimum booked. A first visit, which we might do a problem, or we might just do a meet and greet. A second visit where we might just update the problem list. I might even say, don't come for that one, but I'll leave that there so I can go through this chart. And a third visit to check on what you started, right? We started new medicine, we started new whatever. Let's see how it's going. This gives you a really good foundation for your new patients. So in family med, we have this continuity of care. So we do not have to try and fit it all into the first visit.
So what we do in our clinic is we actually tell the patient, like, this is real, is that our computer system cannot upload a USB with a 300-page file. It like crashes our computer, makes it very slow to try and open that file. So we tell all new patients to either bring us a 10-page condensed summary of their previous charts, or they would just tell us the summary at the intake visit, some of the key things to fill out. Especially when people bring in those big paper charts, we don't accept them at our clinic because it just means that someone in your admin staff is going to spend time scanning each and single one of those pages into the chart. And I don't think anyone will want to do that in your clinic. So, you know, making sure that your front desk staff or your admin staff is happy, that's really important as well.
Yeah, and if you do accept those big charts, because some of you will have a medical center where you do, if you're going to look in there, where's the gold, right? So thinking, don't open the chart and start at the beginning and go to the end. Give yourself a time limit and say, what am I pulling out? As you notice your process, I'm looking for the CTs, I'm looking for the operative reports, I'm looking for the last pap smear, mammogram, colonoscopy. Okay, now, and the problem list. Now you can teach that to somebody else. So you don't have to be the one going in and finding all of those pieces, and just those pieces get scanned in. The rest of it just goes into a box, an archive box, and at the 10-year mark, it gets burnt or shredded, right? So it doesn't all have to be scanned in, and you don't have to have it all under your belt by the next visit. So don't do that to yourself either. I've had physicians have boxes and boxes at home of these big charts. Oh, awful. They just feel trapped by them.
For patients who brings up forms or really long forms, even in the beginning, what is your approach? Do you encourage them to book a follow-up visit to deal with the form together?
Yeah, absolutely. So if this was an old patient of mine, like I've known them for a long time and they have a form, and I know it's one of the ones that takes an hour. So each of the forms in your life have a rule. Do you want the patient there or not? How long do you need for this form? What information do you need before you get started? So if they're a new patient, I have a new patient right now who wants to apply for a couple of the big forms. I don't have enough information. We got the old records across from his past doctor. I still don't have enough information. I just said, no, I'm not doing it yet. I need this, I need this, I need this, and then I can put it together. I know I need an hour for that form. So now I need to allocate an hour. Do I allocate the hour on Sunday at 5? No. Saturday at 8? No. Friday at 2? Maybe. Okay. So start thinking about, when will I do this? Do I want the patient there or not? Do I want the patient to pre-fill their section? Do I want the patient there for page 2 and 3 and then get out of here? I want to do the rest by myself. Okay. So just starting to be curious about your way. How do you want to do it?
Yeah, and in my clinic, it's similar. I tend to have a lower income patient population. So I have a lot of disability forms, disability tax credits, wheel trans forms, and things like that. And some of those forms, like the wheel trans one, you don't actually get paid for. So for those forms that you aren't able to bill a billing code for, I usually have the patient come in and we fill in the form together. So at least I can bill for the time I spend with counseling the patient. And then the other thing is, I guess you always hear this phrase, don't work harder than the patient, because sometimes I get dumped these forms and I don't think the patient has even looked at the forms themselves because the name is not filled out, their address is not filled out. And so assuming if they do speak English and there's no language barrier, I usually ask the patient before giving any form, please look through it in the beginning and at least fill out the parts where it asks you for your name and so on. So when my secretaries are booking the patient in, and they usually ask, what is the reason? If the patient says, I need a form filled out, the secretaries will relay that message and say, please ensure that you fill in what you can on the form as best as you can before the doctor comes in and sees you for that form.
Right, so we have about 3 minutes left.
3 minutes
now.
left, yeah. So maybe we'll take one more question. It looks, so Sarah, maybe I'll let you pick one of the questions from the Q&A because there are many.
So there's a piece here about FHO versus the other ones. Listen, whatever context you find yourself in, starting to be curious about how you do your workflow based on how you're paid is also important. So I get paid to send an email to a patient, 1 per patient per day. You guys do not. So if you're going to do emails, you're going to have to decide, am I doing them for free or am I going to charge for them? And if I'm going to charge for them, how am I going to do it? If you're an FHO, so you get all of the money for this patient once a year, now you might decide you'll max pack your visit so you don't have patients back every week. But then you decide, nope, this is crumpling me because now I've got 5 things to write up and I'm not keeping up with my notes. Change it up. Okay, so just know that you can pivot and change based on what you're given in the moment. So if you're given hour-long appointments, hey, I'll see 5 problems. If you're given 10-minute appointments, oh, now I got to focus and think about things differently. So this is the skill set of the clinical day, is step back and look around and say, what am I getting paid for? How do I get paid here? What is within my day and how do I get this out? So if an MRI report comes in and you're an FHO, you might just pick up the phone and tell them, hey, your knee's fine. I know you still have pain in it. That means you need to go to the physio. Boom. In Alberta, if I do that, I might get $20. Or I say to them, come on back in and we'll talk about MRI. So the way I do that is as I order the MRI, I say to them, when you get the MRI appointment, I'm going to want to see you 3 to 7 days later. So book your appointment with me right away. So then I just need to scan for danger and close that inbox piece because I know they're coming in. So just keeping in mind how you work depends on the context of your workplace. And that's what we do. So we kind of craft you depending on what the circumstance is that you find yourself.
Yeah, and my final tip are related to several questions about how do you plan for inbox management? Like, do you do it? What time do you do it? Morning, night, evening, weekend? I usually have, so you have control of your own schedule. So I usually ask my secretary to book the 30 minutes before clinic starts as admin time and the last 30 minutes before clinic ends as admin time. Those are just already booked in my schedule and nobody can book a last minute patient in those times. Because I have them pre-booked in, I'm usually able to finish all of my admin work by the time the clinic day ends, which is 4:30 for me. And I leave at 4:30, 4:45 or so. So I personally don't ever use book admin time outside of my clinic hours. I book them within the clinic hours.
Yes, please do that. And when you go away on holidays, have a buddy who does all of the work for you. So you're not doing anything on your holidays. Even in solo practice, have a buddy who is within your EMR, who can just get rid of the things and talk about how you want that in basket done while you're away. One of my colleagues wants to read all the consult letters when he gets back. I think he's crazy, but whatever, I'll leave them for him to read. I'll just check for danger while he's away. But no, when I come back, I want it clean slate. They can empty it for me. When I see the patient, I'll know to go look for that cardiologist report and read it then. Like, we need to trust our colleagues that they can do the job for us and have a buddy. And admin time, if that half an hour before and half an hour after suddenly isn't enough, be curious why. Is it because I don't have room in my schedule to get them back? Is it because things are now taking longer? I'm getting more results in. I'm now covering somebody else's inbox, and plan for that to say, no, okay, now I need 2 hours, and now I need an hour, or now I need, and start to redesign that day.
A lot of people were wondering where they can find my templates. So these are usually my templates for plans in terms of counseling patients on the plan section of the SOAP note. The other things in there are also, so I used to teach the practice management lectures for the CMA, but they got rid of the practice management curriculum. And so I downloaded all of the CMA practice management checklists from their website before it was completely scrubbed. So this is where you can access all of the CMA as well as OMA documents that were created by your fellow family doctors. To access this Google Drive, it's in the first video. You just click the first video, it's in the description. And I think someone was sharing the actual Drive link in the questions as well. Great. So thank you, Sarah, for all your time in supporting the residents' academic project, and have a good evening. Bye now.
Good night.
Right, yeah.